Okay, Assalamu alaikum, everyone. Thank you so much for joining today. I know it's been a long gap since the last time we were here last year, but I hope you've had a good year so far. We're excited to start or restart the health series with a talk about heart health. This series is all about preventative health, and so heart health has to be one of the big topics with prevention to help get your health better. Um, we will continue the series again, but after Ramzan. So the next talk is going to be mental health related, but it's going to be after Ramzan, so on the 30th of March. Without further ado, as we usually do, we'll continue. We'll get through the talk. If you have any questions, feel free to put them in the chat. If you don't want to ask them out loud, otherwise, at the end of the webinar, you can unmute and just ask your questions as well directly, and we'll do our best to answer them. But yeah, I hope you find this useful. Without further ado, I'm just going to introduce Dr. Amina bin Hussein, who has very kindly agreed to do this talk, and I'll let her tell you a little bit about herself. Okay, welcome, Amina bin.
Thank you so much. Can you see?
Yes,
Yes, you can. Okay,
yes.
okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for joining us today. I'm very thankful to Allah and Mila Nudum Mubarak. I've been given the opportunity to give this talk, and thank you to SBMAA and Fatma for asking me to give this talk. So, my name's Amina Nazar Ali, sane professionally and at times, and I am a cardiac electrophysiologist, which is a cardiologist that focuses on the electrical part of the heart, and I'll explain some of that. Today, I'm going to be talking about heart health. So, let's get started. And I will go, can you see the slide and everything looks okay? The presentation, you can see my face in the slide?
Yes.
Yes. Okay, very good.
If it's
So,
possible to get your volume a little bit higher on your because we can't hear you very clearly. It's just a little bit quiet.
uh, just a little bit
Your voice keeps breaking as you're talking.
breaking. Okay. Is this a little bit better?
Uh,
Not much better.
it's a little bit better, yeah.
1 minute, just so let me just move the computer close and how is that? Is that a little bit better?
Yeah, that's better.
That's better. Okay, okay, very good. So I'll work like this. That's hopefully you can hear me.
Yeah, we can hear you better
Um,
now.
okay, there. Okay, very good. Sorry, the light had to move a little, so it's a little bit dark, but that's fine. And you can see my face because I
Yes.
can't see it. Okay.
Yeah, we can see your face and the slides.
Okay, face and slides. Okay, let's get started. Okay.
Sure.
So today we are going to talk about heart health. Okay. And um, so topics that we are going to cover. Okay, so today we're going to cover how the heart works. Okay. And I do think that having education about how the heart works is quite important. So a lot of this talk is focused on some education about, basically how the heart works, what it does, what heart disease is, and then we'll identify risk factors of heart disease. And then we'll talk about things you can do, prevention and heart healthy things you can do on a daily basis. And then as part of it, we'll talk about symptoms to watch out for. And then I will tell you about common heart tests that the doctor orders for people, so you can understand why the doctor orders these tests and things. We'll talk about the electrical system of the heart, because that's kind of the part I like a lot. And then we'll talk about wearables, which are a lot of the EKG monitors that people have at home. And then, of course, I'll talk about fainting and the importance of CPR. So I've kind of chosen some topics that I feel like would be helpful to you. You're welcome to ask me anything. Fatima Ben, does this sound okay? Like my volume and the screen and everything, my
Yes.
video, everything's okay.
Yeah.
I'm going to proceed. So the heart is a pump, okay? That's an organ that sits in the chest. It pumps blood throughout the body, okay? So as you can see in this picture, the heart's in the chest. It pumps blood out to the body, and then actually also pumps blood out to the lungs to get oxygen and nutrients, and then the blood comes back to the body, okay? So this is another picture. Basically, the heart pumps blood to the lungs. It gets oxygen and nutrients, comes back to the heart. It goes out to the body, supplying the whole body with oxygen and nutrients that it needs. And in a minute, it pumps about 5 liters of blood. Okay. So very, very important organ. And we refer to the heart and the vascular system, we refer to it as the cardiovascular system. The vascular system being the tubes, the arteries and veins. So when the heart pumps blood, it's pumping blood to supply blood to all the organs, the brain, the kidneys, the stomach, the arms and legs, but it's also pumping blood to itself, okay? And it's supplying itself with oxygen and nutrients. So there's a couple arteries that come off the aorta, which is the main artery that comes out of the heart, a couple arteries that come out like a left system, which is the left main, the LAD, the left circ, maybe you've heard some of those words, and the right system, the right coronary artery. And these arteries supply blood to the heart itself. Now, also, when the heart beats on an electrical system. And so, there's an electrical signal that fires from the top, it travels as a wave to the middle, and then it goes down to the bottom. And so you can see that the heart's beating like this. Also, the heart has 4 valves in place. So these valves are very important for the heart to be pumping. And you can see in this picture, the heart is pumping. I'm sorry. And then you can see there's blood pumping through the heart with these valves helping it. So what is cardiovascular disease? Heart disease could be, disease of the arteries, which is most likely what we mean when people are talking about cardiovascular disease, but it could also be arrhythmias and heart failure and valve disease, and it is really the leading cause of death worldwide, okay? And this is something, heart disease can develop slowly over time, or it can develop, acutely and suddenly. And so really, it's important. There's things we can do to help prevent getting heart disease. And so we'll talk about some of those today. So again, what coronary artery disease is, okay, is when you have narrowing or blockages of the arteries that supply blood to the heart. So over time, you can have buildup of, we call it plaque, but it can be, little fats and cholesterol. It can be platelets and things that get stuck, to the vessel, and it can cause the blood vessel to narrow. And then if the blood vessel itself gets damaged, that itself causes narrowing. And a narrow vessel will then reduce blood flow to the heart muscle that it supplies, okay? And that can lead to a heart attack. And this is a schematic of that. So this is the heart, and these are arteries that are supplying, blood to the heart here. And these blood vessels are a magnification of this little area, okay? So we can see, this is just, a diagram, but it shows, you can see that, oh, look, if that artery is getting more and more clogged, then blood cannot flow to this place, and you can get some dead muscle here. And we call that a myocardial infarction, which is synonymous with a heart attack. So now how can we prevent this progression of disease? This buildup of plaque, we call it atherosclerosis. How could we prevent this atherosclerosis? So there's some risk factors we've identified, and some are listed here that cannot be changed: age, male gender, and family history. So family history plays a very big role in so you can do everything right. It's something you're still, because of a family history, you're at increased risk. And when we talk about family history, okay, it's very important to understand what that means. Family history doesn't just mean at any age. It means after 45 for men. I'm sorry. It means like basically we can say before 55. If something happens before 55 years of age, then we call that premature coronary artery disease, something that could run in the family. But many people over time develop atherosclerosis and coronary disease at a later age. So if somebody's 75 or 80 and they develop it, if your parents do, it doesn't mean, that does not count as family history, actually. Is this okay, Fatima Ben, this volume and everything?
Yeah, you're good. Keep going.
So another thing is that South Asians, okay, are more likely to develop cardiovascular disease than the general population, okay? So that's us, Indians, Pakistanis, we have more increased risk of developing cardiovascular disease. So it's even more important for us to get checked out, okay? We may develop it like 10 years earlier than other people in the general population. So how can we prevent or delay heart disease? Okay, so we've identified some risk factors, and those are hypertension, high cholesterol, diabetes, smoking, poor diet and inactivity, obesity, and stress. These are risk factors that we can change. And there's even more than these risk factors. And like I mentioned, South Asian ancestry plays a role as well. And central obesity, having fat in the mid area, has been shown to increase risk. There's even some other more refined blood tests that people are getting that can increase risk. If somebody has kidney disease, they have an increased risk. And, because I think part of this talk was also focused on women, a history of preeclampsia or premature menopause increases risk as well. I need to be louder a little bit. Right. Okay, so now this part of the talk, we're going to talk a little bit about healthy living, like what we can do. But actually, I'm going to go and also talk about more medical things as well. But in terms of healthy living, what we can do, and a lot of this you've heard before, and we all hear it actually over and over. But one thing we can do is eat smart. And I'm going to talk about this in more detail over the next few slides. Maintain a healthy weight, move more, stop smoking or don't start smoking, manage stress, get vaccinated, follow up with your doctor, and take your medications. Okay, so core components of a heart healthy diet, okay? So here we want to have a lot of fruits and vegetables, and they say kind of to aim for a rainbow of colors to ensure a wide range of vitamins, minerals, antioxidants. Whole grains, so we replace refined grains with options like whole wheat products, oatmeal, brown rice, that are high in fiber. Healthy proteins, we like to choose, some plant-based proteins like beans, lentils, and nuts. or we can choose lean meats like fish and poultry with less red meat. And then in terms of the fat we use for cooking and eating, we prefer you to have vegetable oils instead of the solid fats like butter, ghee, or tropical oils. And then in terms of dairy, we would say opt for low fat dairy, let's say. Those could be helpful things. Now, you may have heard of some diets, and those diets, maybe you've heard of our Mediterranean diet, DASH diet, and plant-based diet. And those are actually recommended by the American College of Cardiology, at least the Mediterranean and DASH diet are. And these diets, they're very similar to the slide I just showed, basically whole grains, fruits and vegetables, olive oil, very similar to things I just mentioned. And here I want to mention that there's a website called CardioSmart, all one word, CardioSmart. It's part of the American College of Cardiology. And there's a lot of recommendations on there. There's also a lot of recommendations on the American Heart Association website. It might be a good resource. The DASH diet was specifically designed for helping to lower blood pressure, and it has recommends like lower salt, but also the same thing, grains and vegetables, fat-free, low-fat dairy, that kind of stuff. And then, of course, we try to cut back on processed meats and foods, cut back on fast foods and fried foods, cut back on saturated fats and trans fats. And then cut back on the added sugars, the simple sugars and starch, and cut back on sodas and juice. Now, these are all, it's hard to do all this, but if we learn some of this, it helps us make our decisions, And this is from that website I was telling you about, CardioSmart. And here we see that the American College of Cardiology recommends at least 150 minutes of exercise per week. And so this is a nice, it gives you some ideas, walking, hiking, biking, swimming, pickleball, housework, and you can break up the 150 minutes a week into 30 minutes, 5 days a week, or 10 to 15 minutes twice a day, that kind of thing. And it also asks, we also asked to add some resistance training, which is, resistance bands, squats, push-ups, lunges, and that could be at least 2 days a week. Okay, so now I'm going to talk about blood pressure a little bit. So hypertension. So one thing that can really help everybody stay healthy is kind of that part of that education, and it's to know your numbers. So blood pressure is something very important to control. And blood pressure is made up of two numbers. There's a top number and a bottom number. And so normal is going to be below 120/80. And then we consider above 140/90 high. And in the middle is, kind of elevated. And so it's important to keep our number more closer to 120/80, okay? And we may start medical treatment at 140/90, but if you have risk factors like diabetes or known coronary disease or something, then we'll want to even start medical treatment at 130/80 potentially, and that's up to your doctor. Of course, before we start medical treatment, we ask for those lifestyle changes, which we just went over, and they're listed here on the right. Move more, focus on nutrition, cut salt, no alcohol, lose weight, don't smoke, de-stress, get quality sleep, which is very important. And mentioning sleep apnea in there if you have sleep apnea, something you want to get checked out. If you need medication for blood pressure, okay, people often get started on diuretics, which are water pills to help get rid of the extra water and salt. They may get started on ACE inhibitors, which is angiotensin converting enzyme, or angiotensin receptor blockers, ARBs.
ACE inhibitors or ARBs, or calcium channel blockers. And there's other ones as well. I just kind of listed a few here. And then sometimes these pills are available in a combination form. So now I'm going to talk about cholesterol. Oh, one thing I want to mention, sorry, about high blood pressure. I'll go back to that slide. So high blood pressure is important to keep your arteries healthy. And so, of course, we're talking about, in this talk, we're talking about arteries to the heart, but in controlling your blood pressure, you're keeping all your arteries healthy. So arteries to the brain, so controlling blood pressure decreases stroke risk, decreases your chance of having a stroke. It decreases kidney problems, and it decreases eye problems. So important to keep your blood pressure controlled, not only for your heart, but your brain, your kidneys, your eyes, and your whole body. So cholesterol, so very important in this talk, very important to keep our cholesterol under control, because cholesterol, and part of that cholesterol, the LDL, deposits in our arteries, and it can cause narrowing and blockages. So with cholesterol, very important to know your numbers. So if you don't get your cholesterol checked, you won't know if you have high cholesterol or normal cholesterol. Okay, so your doctor will check a lipid panel, and that is made up of a total cholesterol number plus triglycerides over 5. I'm kind of going backwards, plus HDL, which is a good cholesterol. So you want that higher, and LDL, which we consider bad cholesterol. Okay. And when we're talking about cholesterol management, we're often focusing on the LDL. And there actually is no magic number, but more recently, the trend has been toward the lower, the better. Okay, so for people who have known coronary disease, okay, they may want an LDL less than 70 or even less than 55, okay? And for somebody who does not have coronary disease, you may allow it to be higher, but you would decide on that based on the presence or absence of other risk factors, like we talked about: diabetes, family history, age, gender, and other things, you know, that we won't talk about too much in detail. But sometimes then if we don't know how low to treat your LDL, we get something called a calcium score. So many people have probably heard of that. And depending on that score, it can help determine how low your LDL should be. And I'll give you an example as I talk about the next slide. So the calcium score is a CT scan, okay? It measures plaque in the coronary arteries, and it helps predict heart disease risk. So higher scores indicate higher risk. And this is used kind of as a risk stratification tool. It's used in asymptomatic individuals, and like I said, often used to guide statin therapy or therapy to treat LDL. And like an example would be if, say, you're a 50-year-old man and you are physically fit, you exercise a lot, you don't have chest pain, you don't have high blood pressure, but you have a family history, and you get your LDL back, and maybe it's 130, 140, you know, what do? Do we treat that, or do we allow that? Is that okay? You know, so that would be a good scenario to get a calcium score, because that calcium score, then if it's 0, okay, which means, oh, wow, this is great, your arteries look great, you don't have to treat that LDL, okay? But if it's high, like 400 or something, then your doctor may say, hey, let's treat that LDL and get that LDL lower, because you have something in your arteries. And in terms of medications for cholesterol, statins are considered first line. These are examples of some statins here. Sometimes people feel some side effects from statins, but if you can tolerate them, they've shown to be very good, not only to get your LDL down, but they stabilize plaque. So meaning that if you do have something in your artery, it makes it a little less likely for there to be a plaque rupture or an unstable plaque, that could cause, a heart attack. So we like to try to give statins to people. And then sometimes if we give someone a statin and their LDL still does not come down, we may start Zetia or kind of a new group of medications called PCSK9 inhibitors. And those are injections people get, once. Two sections. And then diabetes as well increases risk of heart disease. So, and in this case, increases risk of heart disease more in women than in men. So it's very important to get your A1C checked, get your fasting glucose checked. I'm not going to talk too much about numbers, but A1C and fasting glucose, very important to get these checked so we know, and then control your blood sugars. And then it's the same thing you do to control your blood sugars that we've already mentioned a couple of times already. A1C, blood pressure, cholesterol, quit smoking or don't start, take medicine if prescribed, be active, eat more fruits and vegetables, kind of a lot of the same things over there. So far we've talked about things we can do to prevent heart disease, things I just listed. But now we're going to talk about things to look out for. So, okay. So these are some things we may want to watch out for. Chest pain, pressure. Sometimes people don't describe pain. They describe pressure or tightness or squeezing, okay? Discomfort in shoulders or arms, shortness of breath, nausea, vomiting, indigestion, maybe a feeling of like getting a cold sweat and feeling like an anxious feeling, like something is wrong, okay? If you feel these things that happen, if something happens suddenly like this, it's very important to go to the ER to get evaluated immediately, because something could be happening then that is very time sensitive. Like, and if this is a sign of an artery being blocked or something, that is a very time sensitive thing. The earlier you could open that up, the better your outcome could be, okay? Now, sometimes people they don't have maybe acute symptoms like this, but they have very subtle and more predictable type symptoms. And I'm going to take you to the next slide here. Yeah, okay, basically. So I'm actually going to go back. So they may have symptoms like, say, hey, whenever I go check the mail, I get pressure in my chest, but when I come back in and sit down, it goes away, but that is something that is concerning, and we actually call that angina, and that's something you should see your doctor for. And basically this slide is, again, the same thing. Kind of don't ignore concerning symptoms, because if something's happening, taking care of this can be very time sensitive. And I'll show you what I mean when I'm describing some of the tests. But if an artery is blocked, hey, the faster we open it, the better you will be. So it's a good idea to get that open soon. And then, of course, even if you have mild, subtle symptoms that I wouldn't brush them off or ignore them, I'd go tell your doctor about them. And if you do tell your doctor or go to the ER, either one, chances are you're going to get some tests done. So I want to talk to you about some of these tests. And of course, there's blood work. Well, a lot of blood work can help show if you're having a heart attack or not. So yes, there's blood work involved. I'm going to kind of talk about some other tests. So your doctor would get an EKG, okay? An EKG is a test, many electrodes attached to your chest. It allows assessment of the heart rhythm. That's my specialty, actually, that part. And there's signs on the EKG that can alert to a heart attack as well. So very important, if you're having symptoms of chest pain, you go to the ER for them to get an EKG to see, what is there anything emergent going on. But there's many things that we can see on EKG. So this is a very, very nice test. Okay, and then your doctor may order an echocardiogram. An echocardiogram is an ultrasound So it allows you to visualize the heart as a 2D image. It's an ultrasound. So, but with this test, we can see the heart chambers. Are they too big? Are they the correct size? Is your heart pumping strongly? Is the whole thing pumping strongly, or is only some of it pumping strongly? Are the valves opening and closing correctly? Is there any unusual thing in their masses or anything like that? So echo, one of our basic tests, really. A stress test. The doctor may order a stress test, and they may, and there's different kinds of stress tests. I think this is an area of confusion to some people, but what a stress test does, it compares your heart at rest to your heart after physical exertion, okay? And it's not stress like anxiety type stress. It's comparing the heart before at rest and after physical exertion. And I say physical exertion, but for those who cannot do an exercise stress test, we do have pharmacologic, which are medical stress tests, and it still simulates certain things with activity. So we call that comparing rest and stress. And so your doctor may put you on a treadmill. You may go for, say, 8 to 10 minutes. There's a certain protocol where the treadmill starts elevating, and it's hard. And then they kind of compare your heart they compare it in different ways. You can have a stress echo, in which they do an echo before and after, or it could be a stress nuclear, where they do a nuclear test before and after. And that will allow us to see if blood is pumping to all areas of your heart, equally well, even after it's had an increase in demand. Okay, because if it's not, then it could be a sign of a blockage in one of the arteries. Now, or your doctor may not get a stress test. They may order another imaging test. So there's other imaging tests they can order. CTA is a common one, and that allows you to visualize the arteries themselves and see if there's blockages. So every test has their pluses and minuses, or things that they focus on. So there's a reason your doctor may order one test over it. And then if some of these tests come back, with some concerning results, then your doctor may order a cardiac catheterization to do an angiogram of your coronary arteries. And that is a procedure, an invasive procedure, where they go in from an artery. In the past, it has been only the femoral artery, but now they can go in from the femoral and the radial artery, which is located in the wrist, okay? And they can go in and they can look at with the goal of injecting dye into the arteries and then shooting an X-ray, and that dye becomes apparent on X-ray, and they can decide if there's a narrowing that needs to be fixed. So here you can see, this is kind of like just a diagram of a catheter going up, and it goes into one of the coronary arteries here, okay? And this one is the right coronary artery, just because this picture shows that, but there's also the left coronary artery, which supplies probably the majority of the heart, actually. And here you can see they injected some dye, and you can see that there's a narrowing there, okay? So then the doctor decides if they want to put a stent in that, or they want to do balloon angioplasty or put in a stent, or if you have many narrowing, sometimes then people need a bypass, which is surgery to bypass these areas of narrowing, and so your doctor can decide what is best for you. And this is, what a stent looks like. If they decide in that picture, hey, look, we have a narrowing here, and we want to put a stent in, it's a metal mesh. It goes in very nicely, and often we have good results. This is really, stents really save lives. Or your doctor, depending on your symptoms, may order a Holter monitor. And this is a monitor that you wear. It is continuously recording the heart's electrical activity, and it can detect arrhythmias, okay? These are very nice. In the past, there was multiple stickers. Now it's like a patch that you wear. It's really easy. You live your normal life. In our office, we put on tons of these, and they're really helpful. And you get a lot of information. Listen. Okay, so sorry, a few more points. I don't know if I'm over, but I'm going to talk about a few more interesting points. I think it'll be interesting to you. So we talked about education of the heart, risk factors, importance of exercise, healthy eating, knowing your number, seeing your doctor, taking your meds, what to look out for, tests and procedures. And I'm just going to talk a little bit about the electrical part of the heart, wearables, passing out, and just quick word on CPR. So like I said, the heart beats on an electrical system, okay? And I'm mentioning this now because besides everything I talked about, there's a whole set of other heart conditions that people can have. And so these are things that you would pick up potentially on a Holter or EKG. So the heart beats in normal sinus rhythm. A very common arrhythmia that people can have is AFib, where the top chambers are not squeezing, they're kind of quivering, and the bottom chamber is beating irregularly. And you can see that on the EKG here. And the importance of detecting AFib is that it increases your risk for having a stroke. So it's important that if we find someone that has AFib, that we start them on blood thinning, whether they feel they're AFib or not. And that can decrease their risk of having a stroke. And then, of course, we also want to decide if your heart rate is going too fast or too slow. Sometimes heartbeats go too slow and they can't pick up with activity. And that is an indication for putting a pacemaker in. So if you're noticing, symptoms can be of many, many things. And say symptoms of, say, fatigue or shortness of breath can be, the plumbing part that we talked about, like, do they have a blockage? Or it can be the electrical part, which is fast, slow, irregular heartbeats. And this is, again, something you would pick up on a monitor. And this is a repeat of that information. Now, many people come in with their home EKG device, okay? So this is becoming a big thing, and you can see things here, this Cardia device and watches, different smartwatches. And I'll tell you, these are quite accurate and good. And I look at these all the time in my office. So if you're thinking about getting one, I would say, yeah, go for it if you'd like. I would not substitute it for medical advice. So, getting this and then kind of showing it to your healthcare provider or doctor, together, we can decide on what's going on and what's best for you. Passing out, we're in the home stretch here. So passing out, we call it syncope as well, or fainting, very, very common. It is really caused by kind of like a drop in blood pressure, reduced blood flow to the brain, and then body collapses. And really, the body then is able to get horizontal. Your body is kind of telling you to get horizontal in order to supply blood to the brain and kind of wake back up. And these can be triggered by, dehydration, even just standing up too quickly, or many people wake up in the night going to the bathroom and they have a passing out episode. Often it can happen in the bathroom because we also call this vasovagal syncope, and there's a vagal component to it, which is kind of like a full body response. And so these are very common. And I mentioned this because, at our masjid, we have a lot of times when, maybe we haven't eaten and things. And so somebody may pass out. So we want to know if it's best to kind of get them flat and kind of respond to their needs. And typically, when somebody does get flat, they should show signs of movement in the next 5 seconds or something. Okay, so if somebody passes out due to fainting, they're on the ground, and really in a few seconds, they should be moving, maybe blinking their eyes, maybe trying to speak or trying to breathe, moving their hands a little bit, any movement that's fine, but you know, within seconds, if somebody is really not showing any signs of life, or breathing or anything, it could be something more serious. That's where I'm going with this. So we want to then know, hey, look, this person is not responding. What should we do next? And that comes into, CPR. And this is not a CPR course, so I'm not going to tell you, but it is something that, you should know what that is. And so, of course, if we see somebody, they're on the ground, they're not responsive, we would want to call for help. People do chest compressions, and then kind of do that until help arrives. And so, if we were considering taking a CPR course, may not be a bad idea, but it may not be for everyone, but bystander CPR can save lives. So in summary, okay, I hope this was useful in some way. I would recommend you to stay educated, and that was a big purpose of this talk, to be able to teach you about some heart disease and things. Know your risk factors, know your family history, exercise, eat healthy, know your numbers, blood pressure, cholesterol, and of course, blood sugar, diabetes in there. Make sure you see your doctor regularly, take your medications, and know what kind of symptoms to report. I think in that if you did these things, I mean, that would be really, really good. So so that kind of brings us toward the end. And I want to thank you all so much for joining and listening to me talk about this. I hope the AV stuff was okay.
Thank you very much, Aminabin. That was very helpful. So if anyone has any questions, feel free to send them to me privately on the chat box, or you can type them on, or feel free to unmute and ask away.
I have a question.
Yes.
Why do South Asians have a higher rate?
That's a great question. That is a great question. That's a big question. There's not really like a one answer to that, but it has been shown that South Asians have a higher rate. Now, it would be too easy or simplistic to say it's not one thing, like, oh, because of their diet or because of this or that. It's just something that's been shown. I would have a hard time answering why. It's a big question.
Okay.
Yeah.
There was some there's been some evidence as well to show that like hundreds of years ago as well, even during the time of malnutrition and poor, like what our ancestors may have faced in terms of malnourishment, and how the body's adapted has also increased the risk of diabetes and subsequent heart disease, and things like that. So we see it a lot in indigenous communities too, because often, even during the time of colonization, they tend to face a lot of malnutrition and suffering, and that actually has an impact on it too. So there's a lot of research in that area, but I agree that there isn't really a set reason that this is what makes us. But I think there's multiple factors, including our genetics, but this is also what has been faced as we have kind of what our ancestors have faced over time has impacted on our genetics too.
Okay, thank you.
You're welcome.
Annabelle, thank you so much for such an interesting talk. You mentioned statins as a medication for helping lower the cholesterol, the LDL specifically, and then helping with heart disease. As a family doctor, we do get a lot of pushback on starting patient with statins because of side effects, because the fact that they have to be on it for life. So 2 questions. Can you comment on the safety profile of statins and why they're so beneficial? And secondly, Is there an age where you would say, okay, there's no longer a benefit of being on the statins, we can now stop them, especially for the elderly patients?
Okay, yes, yes. So thanks for your question. This question had to do with statins. So I'll tell you what, actually, I practice cardiac electrophysiology only. So I actually do not prescribe anything for cholesterol. I gear this talk toward general heart health. So I have a lot of heart health in there. But okay, my thought on safety, overall, I yes, from what I hear is that there's a lot of pushback on statins due to muscle aches and pains, and then the studies that have shown increased rates of this or that. But overall, because of the benefit of statin, that I feel like that safety is good. In terms of that's kind of all I can say about that part of it. In terms of the age, yeah, I think after 75, 80, the benefit, you know, in a really kind of crude way, if nothing has happened yet, you're in a good place. Like, so something like that, if somebody wasn't tolerating statins and they were at that age, I would be less, I would appreciate less. But like I said, I actually don't handle people's cholesterol. I see what they're on when they come visit me in the office, but I could defer to many of you.
Yeah. So Amravin, there's also there's a comment saying thank you, Shukran, for an excellent and insightful session on heart health. And then there's a question. If you typically have low blood pressure, how would you monitor it if it increases, not actually knowing your starting numbers?
Sorry, can you
Yeah, so if you typically have low blood pressure, how would you monitor it if it increases, not knowing your actual starting number? So if you don't actually know what your original blood pressure is and you might be more prone to lower blood pressures, how would you know if it's increasing?
So, many patients get a home blood pressure monitor cuff. A common brand that people get is Omron, OMRON, but there's a lot of brands out there. And the cuffs that go around your arm are better than the cuffs that go around your wrist. So the way you would know is by checking and keeping a log. And so many patients of all of ours, they'll check it once in the morning, once at night. They'll write down the three numbers, the two blood pressure numbers, and then the heart rate number, and they just kind of keep a log. And so when I ask my patients to keep a log, I'll say twice a day. Plus, if you feel bad and if you feel something funny, like, oh, I feel lightheaded, I'm going to take so that gives us an idea of where their blood pressures are. There's some people who they run low. There's some people who run high. Some people have very labile blood pressures, up and down, up and down. Those are very hard to treat. So it ends up being just monitoring it over time. Uh,
Yeah, and just
yeah.
to add to that as well, actually, so in clinical practice, if your blood pressure is generally low, if it's starting to rise, yes, if you're normally sitting at 100 over 70, and then it starts to rise until it reaches numbers like 130, so 130 depending on if you're diabetic, but 135, 140, that's when we start to kind of treat anyway, but it's worth keeping an eye on it. So you don't have to check it on a daily basis or even on a weekly basis unless you actually have blood pressure problems. But if you're worried that when you are actually tracking it, it's useful to check it twice a day. So in the morning and in the evening when you're resting, and you check it for 5 continuous days, and then take those results to your family doctor, because then they'll be able to see and track it and advise you further. But generally, even if you normally have a low blood pressure at 120 over 80, even though technically that would be higher for you, in terms of the evidence to suggest that it's cardiovascularly unsafe and it needs treatment, there isn't evidence for that. So you wouldn't usually be on treatment, even if yours is normally low. It would just be kind of continuing to monitor it until it reaches those numbers when we have evidence to show that this is dangerous. I hope that makes sense. Do you agree, Amin?
Yes, yes, I do. Yeah, that does.
And there's also, you can monitor your symptoms as well. So if your blood pressure is higher than normal, you may get headaches, blurry vision, dizziness, just generally feeling unwell. So any of those kind of symptoms, definitely get your blood pressure checked, because it may show, that you do have high blood pressure. Sometimes it may show that you have low blood pressure. So look out for symptoms that you have that you don't normally have, and go get your blood pressure checked.
Absolutely. There's another question too. So, they say, Salam, in heart conditions, emotional stress is well known. Does intellectual or mental stress also exist?
Yes, absolutely. This is, yes, a well-known thing as well. Intellectual, I mean, I think with these, with all heart disorders, all heart disease, there comes some emotional stress. And even around procedures, there's some emotional stress as well. Um, so yes, I mean, and in fact, and this may not be exactly your question, I'm not sure, but certain professions have higher um, incidence of like cardiac disease, like law enforcement. They'll have heart disease at an earlier age. They have increased prevalence of heart, and that may be because maybe some adrenaline rush or something like that, I don't know. But there's some emotional, and we consider that's mental stress as well involved with heart disease. And after bypass or heart surgery or any heart procedure, sometimes people can feel something, maybe like some more emotional, uh, that state of emotional, stress. But yeah, I've noticed it. I don't know how else to comment on it per se.
There's a really helpful comment too by Sarah Hussain. She says she's a medical illustrator and her company specializes in cardiovascular patient education. She says we've actually made an app with most of the visuals, and so there's a free heart app that they made called HX Heart app. It's in the chat box. So if you're interested, she said it's got an expansive library of interactive 3D models, images, and explanations for every kind of cardiovascular condition and treatment options. So if you think that might be useful or you want more information, please check it out.
That's great. Thank you so much for that. HX Heart app. Thank you. I'll definitely.
Yeah, and then there's another question. So, we hear of very healthy people just flip, collapse, and pass away. So, heart failure, how does that happen?
Yeah. So yes, we've all known people who collapse and pass away. Okay. And that can be, so I mentioned that, we don't always know, right? Because we don't always check when somebody passes. But since talking about this heart disease, when somebody gets a blockage in their artery, it can come on suddenly. We call that an acute MI. Sometimes we call it ST elevation MI, acute MI, okay? And that blockage blocks the whole vessel. And it's very important to open that up very, very quickly. We ideally like to do it within 90 minutes of presentation, basically. So
So, but if that blockage doesn't get opened, and that could be many reasons, um, that then that person could actually die. So, so I think when people do collapse and die, that is one of the reasons. But there's other reasons as well. There's other reasons as well. So, um, a list of things. And but since we're talking about the cardiology part of it, sometimes if that blockage doesn't get opened, or somebody may not die suddenly, but it, part of their heart can part of their heart muscle can die, and then the heart is weak or not functioning well, and we call that congestive heart failure. So congestive heart failure is that part of it. Congestive heart failure is actually a bigger clinical diagnosis. Whether your heart could be functioning well or not, you could still get congestive heart failure. But congestive heart failure is one of the things that can happen if somebody has just blockage of the arteries. Another thing that can happen is that once you have something going wrong with the heart, like a blockage or other things, you can have electrical disorder at that point, and you can have ventricular tachycardia, ventricular fibrillation, and that's basically the electrical system going chaotic, and that then causes actually a cardiac arrest or sudden death. So, and that can cause you to collapse suddenly or pass away in your sleep. When somebody does die suddenly, it is often cardiac, or one of these things, but it doesn't always have to be. It can be a blood clotting in your lung. It could be a massive stroke. It could be, a big metabolic disorder that occurred. So it could be other things as well. It depends on a lot of things. Yeah. Did that answer your question a little bit?
Yeah, I think you answered.
Okay.
Okay, and then there's a really helpful ayat that has been put on the chat too, that relieves heart uh so it brings calm to the heart and relieves intellectual stress. And it says Allah bi dhikrillahi tatma'inu tatma'inul qulubu. Through the remembrance of Allah, hearts find peace, easing mental and intellectual stress. Okay, so it's in the chat box if you want to check it out. There's another question. So lots of times the symptoms of heartburn or acid reflux feel like you're having a heart attack. Is there a way you can tell the difference?
Oh, this is a great question. Perfect. Okay, this is a very good question. So yes, so chest pain can be the heart, or it can be reflux or heartburn, or it can be just your chest wall or gas or something. So if you have chest pain, we hear, okay, go to the ER, go to the ER, go to the ER. And the ER then decides if they separate it into cardiac and non-cardiac. Okay, non-cardiac includes heartburn, gas, reflux, chest wall, unknown thing, but so when you get to the ER, if you have chest pain, they do an EKG. Okay, their EKG can show some findings of heart attack, or even even not an acute heart attack, maybe like a subacute type heart attack, or maybe even just angina. And then the ER gets blood work. And maybe you've heard of something called troponin, or a cardiac enzymes, we call them. And those, if it's a cardiac problem, can sometimes be elevated. All right. So they would, they'd get a chest x-ray and troponins, and they probably get a bunch of other blood work, which includes, electrolytes, kidney function, and then a blood work that causes like a blood count and all that. And then maybe a chest x-ray as well to see what's going on. So between the blood work, the EKG, and the chest x-ray, I would say, you get a very good idea of, and some vital signs and things, and physical exam, you get a very good idea of where this is going. And sometimes even after that, they say, we're still not sure, we don't know. So they may, let's keep you for 6 hours and recheck the blood work. Okay, because sometimes things have a late, so they know, okay, yes, after their first assessment, they either say, okay, definitely not cardiac, you can go home, or they'll say, we want to keep you to make sure we rule out cardiac, or keeping you for a good 18 to 24 hours to rule out a cardiac event.
Yeah, that's a great question actually, because so often you hear that, you'll hear people saying that they're having chest pain, or and they'll kind of write it out as acid reflux, or conversely, people will come into hospital thinking they're having a heart attack, and it's acid reflux, and they get sent home. And so a lot of the time they don't want to come in because the next time they have severe pain, they think, oh, it's just acid reflux. And so it's important if you're having any kind of severe chest pain where you're having to clutch your chest, especially if you're having any sweating with it, and the pain is not easily just getting better on its own, you do need to be seen. Even if it does get better, when you've had severe pain, it's really important to see your doctor, even if it's the next day, even if the pain has completely gone away. And I'll tell you a personal story actually, very fairly recently. My the same thing happened to my dad. He was in masjid, and on just before they were going home, he kind of mentioned to my mom, he's like, oh yeah, my chest was really hurting. And he kind of looked a little bit sweaty to my mom, and then he was like, nana kind of gas hase, right? And then my mom only told me the following day, and by that point his pain had gone, and they were supposed to go on a trip that night. And I insisted to my mom, and I said, I don't want you to travel until he's gone to the ER. And when he went, they found three blockages, and within the same day, he'd had three stents put in. And his pain at that time, he had no pain. He didn't even want to go to the hospital. So it's important. If you're worried, if you think it's severe, get it checked out. It's always better to get told 5 times that it's nothing, it's acid reflux, rather than you not going and it happens to be that one time when you should have. So I think the take home should be, if it's something that feels severe, let someone know. Let someone who can assess it know, and let them make that decision. So yeah, I hope that helps. Um, and then there's a question. So how much do our current eating habits and lifestyle choices contribute to our overall risk of heart attack?
Okay, that's a good question. So I think that was a good portion of my talk. This is a this is something where we can't give a percentage because every person is different with that. So all those risk factors, family history, whether you have hypertension, whether you have cholesterol, whether you have diabetes, whether you have obesity, or central obesity is a big one too, because a lot of us carry a lot of our weight right in the center area. So those are the risk factors, but by our eating habits and our exercise, we can control our hypertension, which is a risk factor. We can control our cholesterol, which is a risk factor, and we control our diabetes, which is a risk factor. So the reason we say, because that's the only thing we can tell, patients to do, that's in their, the kind of the ball is in their court for that somewhat, for, being and healthy. And then, but in order, eating right, staying healthy does play a role. So yes, like how much it does for any given person, it's hard to quantify that. But it's significant, I would say.
Amazing. Thank you very much, Amabin. I think, sorry, were you going to say something?
On the same note, people can do everything right. They can stay healthy. They can be thin. They can get everything checked. They can do whatever their doctor says, and they're still, of course, like we don't know, what the future holds. Things can happen. Even so, it's not anybody's fault. It's just something that happened. Things can happen even when you do everything right.
Yeah, I was just saying thank you so much for this really insightful talk. I hope, and I'm sure everyone's found it really useful. As always, if any of you have questions, follow-up questions, please feel free to reach out. You can reach out to your Umar Sehat leads. If you have any of our contact details, you can reach out to us. I'm happy to put my email address on the chat box, and I can direct your questions. Um, if it's something we can help you with. But yeah, please feel free to ask. The point of these talks is to help prevent these kind of big heart events. So yeah, please do get in touch. And I hope you found this useful. Inshallah, we'll be back in on the 30th of March, I believe it is, and it's going to be a talk on mental health with regards to OCD or obsessive compulsive disorders. So please join us. Thank you so much again, Amna.
Thank you to all of you joining.
Are you happy just to hang out for a couple of minutes in case people still have questions? Yeah? Okay, so we'll just hang out as people just fall off.
Was the audio okay? The AV
Yeah. Yeah, it was just at the start and then it was fine. We could hear you properly.
trying to talk loudly.
Yeah. There's a lot of messages for you in the chat box as well, just thanking you.
Oh, absolutely.
Yeah.
Questions,
Sorry, what was that? Your voice was cut off. I missed that.
if anybody has any questions, yes, I'm speaking.
Okay, perfect. Thank you. Rashida, been out of interest, what do you do in your practice with the cholesterols? Because I know the data, I think from 2020 had said that after 75, you wouldn't start anyone on cholesterol medication. Um, and then between 75 and 84, there's not a lot of evidence to suggest you need to continue it because essentially you're not, with cholesterol lowering, you're treating long-term risk, right? What do you tend to do?
Yeah, so a lot of times elderly people do come up and say, I don't want to be on these medications anymore.
Yeah,
Been on them my whole life. So the cholesterol medication is usually the first one that I take off just
yeah,
because measuring risk versus benefit at that age, um, there isn't much really. Like, I mean, Abin said, if there hasn't been a cardiac event up until that age, the chances are that the statin really isn't going to help them much past that
yeah,
age. Um, and it's not going to prolong their life much past that age as well. So I do tend to
yeah,
stop the statin, but some patients do tend to still have higher cholesterol levels. So in which case, I will consult a cardiologist and see what they recommend as well.
nice. Yeah, my practice is similar too. I don't tend to check it much after like 84 onwards. I don't even put it in the labs because
No,
I just don't
no,
see the point of it. But
yeah,
yeah, generally, if a patient wants to stop it, then I'll stop it. Otherwise, I tend to keep them on. But after 84, then I'll talk to them about whether they even want to be on it. Yeah.
yeah. And then starting them on is just education. Because,
Yeah.
like I said, a lot of patients are like, oh, muscle pain. I don't want to be on the medication forever. If my cholesterol level improves, can I stop it? So there's a
Yeah.
lot of education around, yes, there are side effects, but, stick with it. There are others we can try. Um, and then your cholesterol has improved because of the medication. So that's why
Yeah.
you need to be on it. So lots of education
Yeah.
around that. A lot of people do tend to, accept it, but there are some that they just won't. And then you just have to continue to educate and document.
Yeah.
Yeah.
Okay, I don't think there are any more questions, so I'm gonna end the chat if that's okay with you, Aminabin.
Very good.
Yeah.
Absolutely. Thank you
Thank
so
you once
much.
again. My
So,
pleasure. Take care. That is.
Thank you.